This is part one of my interview with Dr. Marielly Mitchell. She is based in Los Angeles. She is a doctor of occupational therapy. She's also obviously an occupational therapist, sensory integration, and swallow assessment and intervention. And I met her at the AAPMD conference where I gave a presentation. And we just end up standing next to each other and talking. And we talked for quite a bit, and we connected on quite a few points because she's actually interested in postural restoration because she's heard of it. And I'm obviously very interested in the oral cavity, and I have a lot of videos about jaws and tongues and teeth. So we kind of had a meeting of the minds. And what I know, even if now she's an occupational therapist and she works with mostly pediatrics with children, but what I know is that I'm treating or I'm working with many people who probably have leftover issues from childhood, oral cavity issues, or sensory processing issues that were never diagnosed. I am that. All my issues started in my childhood with my visual system and my jaw. And when that happens, the effect, it will come back to the neck. So if you've watched my channel, any of the videos on my channel, often I talk about the neck and how it all comes back to the neck in breathing, but even the breathing comes back to the neck because you become a neck breather. She's an expert in all of this stuff with pediatrics. And again, she's in Los Angeles. I visited her when I was actually out there last month. And her business is pretty amazing. Her location is amazing and inventive. And I think in the next video, I'll show some pictures of it. So why would you care about this video? Because all the things that she's talking about, if you have kids, you have to look out for this. You may yourself be in pain now as an adult because of what was going on in childhood that was never noticed and never treated. So that's why everything she talks about, or that we talk about, is applicable to postural restoration and what I'm doing with adult clients right now. This is why I'm talking to this individual, because it all comes back to the neck from a PRI perspective. And that's huge. And I always think about my own experiences. And
Totally.
if I had a perceptive dentist or anyone who could have said, you know what, this
Yeah.
mouth doesn't seem right.
Yeah.
How many people get put in this position that they do not know that there's anything wrong with their mouth? And down the line, they then have to come see people like me because their body has fallen apart on them.
Yeah.
And I know from my own experience, my primary issue was my palate, my jaw position, may have been influenced by a visual system that got a little bit funky. Sensory processing completely broke down. Another thing I want to talk to you about,
Yeah.
because I'm dealing with sensory processing all day long. Every PRI patient is not processing sensory input appropriately.
And people just are like off their matrix almost and not in their body, and they don't perceive things correctly,
Yes.
which typically exacerbated so much by the visual field, their visual skills and like perception of what they're actually perceiving. But yeah, that's a whole, I address sensory processing in a very like pediatric sort of way, but that's not to dismiss that like those types of techniques and things like that wouldn't work for an adult either, right? Like there's like adults could really work, probably rebounders would be great for people as long as they're jumping the right way, right? Or like if they were on swings or doing like vestibular rehabilitation with like a vertigo specialist or something like that, if it came to that. Most people don't see people like that unless it's really 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 bad.
Mhm.
But it doesn't need to be, it shouldn't have to be so bad for people to get intervention, you know?
So I want to know who you exactly, I know you work with children mostly.
Yeah.
Yeah. So what are you seeing at such a young age that they have to come in to see you? Or what is the parent seeing or what is the teacher seeing that makes them think, oh, this is something that has to be addressed?
Yeah, so usually like what I see is typically kids who have a mix, like a hybrid of some neurosensory motor issues going on, and then also a lot of like mouth issues going on as well, because the mouth is always kind of a reflection of what's going on with the rest of the body.
Okay.
Those children typically didn't have an appropriate sensory motor development through their developmental milestones. So when you don't have that,
Could you explain what that would be? Because
yeah,
most people are
so
not going to know what that is.
yeah, so what that is so those are those babies who like didn't roll at 3 months. Maybe they sat a little bit late, or if they did sit, they never like rotated their trunk, right? So they never learned their midline, and then they're right from their left and things like that. So then they have a really hard time knowing their lowercase d's from their b's or their p's and their q's because they can't mirror because their own like internal like body scheme and
Huh.
like map is really off. So especially babies who didn't crawl. So the CDC just released this whole thing like, oh, crawling's not important. And I'm like, all the pediatric therapists are like up in arms about it, including myself,
Oh,
because
wow.
it's actually a really, really huge, important milestone. Sorry, there's a paramedic. It's a super, super important milestone because it integrates so many primitive reflexes, but most importantly, it develops your corpus callosum, which lets you know your top and lower half of your body and your left and right. And it matures the vestibular ocular relationship because you start to move your head and separate your eyes from your head, right? And if your vestibular system isn't as robust as it should be, your ocular system with your eyes isn't either. And so those kids typically have handwriting issues, hand-eye coordination issues, overall coordination issues, and they typically go straight to walking, and they're just in their frontal plane of movement quite rigid, right? There's no trunk rotation in their movement. They're super stiff, they're hyperextending, all that kind of stuff. There's no co-contraction, or they're like noodles, right? And they're just slumping everywhere, and they can't motor plan their way through their world. And it's really hard for them, which then compounds on itself. Then it's exacerbated by mouth breathing and poor sleep, and the nervous system just really takes a hit from all ends. Does that make sense?
Yes, it was a lot. So
I know. It's really hard to explain. I can really make it like short, and I can't.
No, I understand. That's why I have 300 videos on the subject of postural restoration. It's
like,
not
I can't put it in square. Yeah.
It's not something that can be described in just a few short sentences, because I mean, what you're talking about, people without they can't rotate. They don't have an appropriate frontal plane. That is the people I'm working with. So anyone who watches or studies PRI or watches the channel, and my channel or any other channel, I don't know. Well, if people watch anything on here, I've talked about all these things. These are things that people cannot do when they're stuck in this left AIC, right BC pattern, because that dominant side has become too dominant and they can no longer rotate and side bend. It affects their visual system, whether they realize it or not, because once your head is in a position like this for too long, it becomes the default position.
Yeah. It's almost like these adults, it's almost like these adults, like we get so many torticollis babies, right? And they're like this or like that. I feel like they grow into the adults that you see, and no one, it's like residual torticollis that nobody really like remediated. And there's this whole neurosensory component to this, right, that like I really geek out on. But like I also want to really, like, from like AMPD, like with the conference we were both at, like I really don't want to dismiss the structural component to this and the fascial tightness that people can have, and the restrictions that they literally like have, or like cranial like pressure compression that these people, like, nerves can't fire, or they're too tight in some way. So they literally just move in a way that limits their motor response, that then creates this like super, super ingrained poor motor pattern. And then they can't undo that. And they do it forever. And then you throw in the visual neglect that they can have too. So it's like, there's the neural component and the sensory component and all the nerves. And then there's the structural part too, that like really, it's like you have to address both, I feel. And I feel like
yeah.
So it's not gonna work.
It's not gonna work, and that's the thing. That's why I'm on, not my high horse, but when I talk about postural restoration, I try to get, it's taught in a way that, because they're teaching physical therapists first, and mostly physical therapists and then strength and conditioning people, they're teaching it in a kind of a biomechanical way, because they have to meet the people where they're at, you know. But if people never get past those primary courses, they're never going to realize that it's really a sensory system. It's a neurosensory input gives you the muscular output, and all PRI techniques, even if it looks like a left hamstring technique or a left adductor, it's completely neurosensory, sensing the ground and then sensing the position that your body's in. And if you don't use, and just by default, you're going to open up left periphery and decrease right periphery in a lot of techniques. So it's still, people don't realize that the neurosensory aspect is built into the techniques. They're still thinking, oh, this is a left hamstring exercise, and I'm going to get that left hamstring so strong. But of course, the more tension they create, if they make it into a gym exercise, the less it works, because they're just jacking their system up and creating more tension. So I'm always, so this is where I want to, you were saying, I want to mention or question. When you're working with the children who are showing these fascial or muscular tension, is it the lack of sensory integration that is driving that tension, or is it structural that then drives neurosensory issues? Like, were they born with a structural issue? Because some people are, and then it throws off their sensory processing.
Totally. So it really, so like just to piggyback off of that, like I always like when I have like my team and stuff like that and I'm training people, I always remind them I'm like sensory precedes motor. You need input in order to have output, like to piggyback off your hamstring
Yeah,
comment. Like, they
yeah,
can't feel it, they can't use it, right?
yeah,
So it really depends on like that, which is like probably not the answer everyone's gonna like, but it's like it's very dependent on the case. It
yeah,
really
yeah,
truly is. Like
yeah.
it so is. And like I will know if this is a structural issue, if I'm using my sensory like techniques to elicit a specific motor response and it's not going, or
Mhm,
it's going the opposite direction, or it's just a really like kind of like unique or interesting response that I'm not trying to elicit. And
mhm,
so then I will send them typically to an osteopath or a like a fascial like body worker.
mhm.
And then typically if I see a really quick response with that, then I know that there's some type of anatomical issue.